Hello KJR readers, it is a great honor to present our study and listen to author section on KJR. This is Hyemin and I'm going to present our study named Prognostic Value of Sarcopenia and Myosteatosis in Patients with Resectable Pancreatic Ductal Adenocarcinoma. Muscle parameters are associated with poor prognosis in various diseases. Sarcopenia refers to loss of skeletal muscle mass and strength and reflects muscle quantity. Myosteatosis refers to excessive fat deposition in skeletal muscle, which leads to loss of skeletal muscle quality and now is considered as distinct disease from sarcopenia. CT is the most commonly used non-invasive method in assessment of muscle. Pancreatic ductal adenocarcinoma (PDAC) is one of a dismal disease with extensive muscle loss. The purpose of our study is to investigate the prognostic effects of sarcopenia and myosteatosis in patients with resectable PDAC who underwent curative surgery using quantitative muscle measurement on preoperative CT. This was a retrospective study, and we included patients with resectable PDAC according to the NCCN criteria who underwent curative intent surgery, and after the exclusion, finally 347 patients were included. To evaluate the muscle quantity and quality on CT, we use single axial image on portal venous phase. We automatically selected the image at inferior end plate of L3 vertebra. Then using the pre-developed automatic segmentation technique, we segmented skeletal muscle area. And we gathered clinicopathologic data. Currently, there isn't standard diagnostic cutoff for sarcopenia and myosteatosis yet. Therefore, in this study, to determine sarcopenia, we use the skeletal muscle index, which is calculated as the skeletal muscle area divided by H squared. To determine myosteatosis, we use the mean attenuation of the skeletal muscle area. Then we categorize the patients into 8 subgroups dichotomized by age, sex, and BMI. Using Kontal and O'Quigley method, the optimal cutoff values for sarcopenia and myosteatosis in each subgroup were separately derived. Then we classified the patients into following 4 groups according to the muscle types, which is normal, sarcopenic, myosteatotic, and combined muscle type. We did survival analysis according to the muscle type, and the primary outcome was overall survival, while the secondary outcome was recurrence-free survival. We plotted Kaplan-Meier survival curves for overall survival and recurrence-free survival according to the muscle types, and also conducted univariable and multivariable Cox proportional hazard regression analysis. The characteristics of included 347 patients are summarized in the table. This table shows derived cutoff values for sarcopenia and myosteatosis in each subgroup. Based on the cutoff values, about 54.2% patients were diagnosed with sarcopenia and 54.8% patients with myosteatosis. Regarding muscle type, each muscle types were relatively even distributed. This is the Kaplan-Meier curves of the overall survival, OS, according to the presence of sarcopenia and myosteatosis. The Kaplan-Meier curve showed a worse OS in the patients with sarcopenia than in those without, and also shows worse OS in patients with myosteatosis than in those without. The Kaplan-Meier curves also revealed a significant difference between the muscle types regarding OS. This is the Kaplan-Meier curves of the recurrence-free survival, RFS, according to the presence of sarcopenia and myosteatosis. There was no significant association between RFS and sarcopenia. In contrast, Kaplan-Meier curve showed a worse RFS in patients with myosteatosis than in those without. The Kaplan-Meier curves of RFS were not significantly different according to the muscle types. However, the normal muscle type tended to be associated with better RFS than the other muscle types. This is the result of Cox proportional hazard analysis. The myosteatotic and combined muscle type were associated with significantly worse overall survival than the normal muscle type. Meanwhile, Only the myosteatotic muscle type was related to a significantly worse recurrence-free survival than the normal muscle type. I'll briefly show two cases. First, actual image of portal venous face shows a 1.3 cm mass with low attenuation in the pancreatic uncinate process, and the mass shows less than 180-degree contact with the sperm-mesenteric vein and considered as resectable PDAC. Automatic segmentation indicated a normal muscle type, and after the curative surgery, the patient was alive without tumor recurrence for 82 months until the last follow-up. Another case, axial CT image of portal venous face shows a 5 cm mass in pancreatic body and considered as resectable PDAC. This patient was considered as myosteatotic muscle type, and the patient underwent curative surgery. However, the tumor recurred after 4 months later, and patient died 11 months post-operatively. So, our study indicates that myosteatotic and combined muscle type had poor overall survival in patients with resectable PDAC. And also, myosteatotic muscle type was associated with significantly higher tumor recurrence rate than the normal muscle type. In conclusion, preoperative myosteatosis was associated with poor overall survival and recurrence-free survival after curative surgery in patients with resectable PDAC. In this regard, preoperative assessment of muscle quality may be valuable for treatment planning and postoperative treatment, such as optimization of nutritional support and physical therapy. Please refer to the email shown for further inquiry. Thank you for listening.